So with all your permission, sir, I'm starting, sir. There was some glitch with live. Yeah, I'm sorry for the delay, sir. Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Manoj Toshniwal, sir. Sir has done MBBS, MD, DM in clinical hematology, consultant hematologist at Jeevan Amrut Hospital, Aurangabad. Today he is going to speak on a topic lymphocytic function disorder. Let me tell you overview of the topic. Lymphocytes are one of the several different types of white blood cell. Each type of white blood cell have a specific function and they all work together to fight illness and disease. White blood cells are an important part of your immune system. They help the body fight antigens, which are bacteria, viruses, and other toxins that make individual sick. But what happens when the functions of lymphocyte are in disarray? To learn more on this topic, I would like to invite Sir and hand over this session to Sir. Sir, over to you. Kindly proceed from here.
Thank you, Faraz, for your kind introduction. I have some slides made, so I'll just quickly try to share that. Hope this is visible. Lymphocytic function disorders. Is it visible for us?
Yes, sir, it's visible on the full screen. Fine.
Slides are moving.
Yes, sir, it's moving, sir. Perfect.
So, good evening, everyone. Manoj Toshniwal, working as a consultant hematologist, bone marrow transplant physician at Jeevan Amrut Hematology Center, Aurangabad, now called as Chhatrapati Sambhajinagar, Maharashtra. Now, today, as per our last discussion, there were some suggestions about lymphocytic function disorder. So today we chose this topic for the discussion. First of all, I would like to thank this group, MedTalks, for arranging such a good virtual platform where we can discuss something scientific, medical terms with our medical fraternity all across the globe. Every month, they are coming with this type of talks where knowledge sharing has become really very easy due to availability of such virtual platform. I also thank all the participants who have tried to find some time out from their busy schedule. Today is a weekday, UPD day, and in the evening today we are discussing something scientific. So to them also, I would like to thank you. I'm not someone who is expert. You all are expert because you have all the busy OPDs. You are seeing patients since last many years. But I know something more about these lymphocytes, and that is why I am delivering this talk. So I would like every one of you to keep this as a dialect rather than me teaching or preaching something on this lymphocytic function disorder. If you have any point, any concern, any question in between as well, please feel free to drop your question in Q&A box so that we can take forward to the discussion. First of all, we need to see the basic thing, the basic anatomy of our lymphoma. So today's topic is lymphocytic function disorder. It's very rare topic, rare disorders, but some suggestions were there. So I thought maybe we'll just quickly touch upon the lymphocyte because it is attended by various people, various fraternities, various general practitioners to the experts. That is why I'll just touch upon this topic. So this is the blood cell development in the bone marrow. Blood stem cell. Initially, this pluripotent stem cell get developed into myeloid stem cell. Myeloid stem cell, this is your pluripotent blood stem cell. It develops first into myeloid and lymphoid. This segregation will be there. And today we are discussing about these lymphoid cells. These lymphoid cells, initially they are lymphoblasts, and then they mature. If they mature inside the bone marrow, we call them T lymphoblast. If they go inside the thymus and there they have their maturation, they are T lymphoblast, and some of them develop into a natural killer cell like property. They are called NKT cell. It's part of T cell only, but because of different immunoprofile, we call them NKT cells. Even these B lymphocyte after maturation become plasma cells. This is normal lymphocytic development. In myeloid series, we all know that myeloid series develops into the erythroid, the megakaryocytic, and myeloid lineage. This myeloid stem cell erythroid lineage goes for the red blood cell formation. The myeloid stem cell megakaryocytic series goes into the platelet formation, and this myeloblastic series goes into the granulocyte, eosinophil, neutrophil, basophil. All these are the basic cells in our body. So we will be focusing on this lymphocytic function disorders today. Okay. So these are lymphocytes and this is what they function for. So initially, these are the primary organs, that is bone marrow, and this is thymus. These are hematopoietic precursor cells. From bone marrow, they go into the thymus, where they develop into a naive T cell. If they mature into the bone marrow, they are T cells. From there, they go into the secondary lymphoid organs, which are various, right from various lymph nodes everywhere in your body. They circulate as mature B cell or mature T cell. T cell also go into effector T cells, which are non-inflammatory peripheral, and in inflamed peripheral effector T cell, which present the antigen. So this is how the lymphocytes, various lymphocytes, get their development in our body. Main function of our lymphocyte is to have the immunity. So whenever in our body, let's see how exactly this immunity works. So whenever a foreign material comes to your body, there is initially non-specific chemical or physical barrier where skin, mucous membrane, stomach acid, lysozyme, tears, these are all things. And then expulsion by coughing, sneezing. But once they go into the natural immunity plays into it, where it is complement mediated or the cellular macrophages, neutrophil. And last is the adaptive, that is the most developed immune system, where the third blockage is there for those organisms. It is cellular if it is mediated by the T lymphocyte. It is B lymphocytic which produce the antibody, that is humoral immunity. Whenever we are discussing about the lymphocytic function disorder, there is problem in this thing, that is cellular immunity or humoral immunity. Whenever there is problem in this cellular immunity, T cells are at problem, and humoral immunity antibodies, then it is B cell are at the. Okay, so this is how it is. So the initial response for the cellular immunity is phagocytic response. Usually the first line, foreign pathogen, non-specific, defense against the macrophages, phagocyte also. But lymphocytic is second line, defense against the foreign pathogen, long-term, highly specific targeted response to particular antigen. So when we consider lymphocytic function disorder, it can be of two types. One is acquired or second is innate immunity. Acquired immune disorder, lymphocytic function disorders are like whenever lymphocytes are low, like in viral infections, or even in multiple myeloma for that matter, where lymphocytes are not functioning. In patient who has received lymphocytotoxic medicine, like cladribine for hairy cell leukemia. If it is lymphocytic function disorder because of that cladribine, it is acquired immune disorder where they get problem with the antibody production. immunoglobulin levels will be low, and they develop various types of infection. HIV, HIV is the CD4 cells will be low. This CD4 T lymphocyte being low, lymphocytic function disorder, and others are innate lymphocytic function. So acquired are like malignancy, viral infections like HIV, and some of them are like after the what you call some chemotherapy. Okay, so these are acquired lymphocytic disorders. Then comes the innate disorders of lymphocyte. Innate lymphocytic disorders are when there is poor maturation of lymphocyte because of various problems. These are rare, but innate immunological disorders are particularly seen in childhood, where you have to see them if they have the manifestation like recurrent fungal infection, recurrent bacterial infection, recurrent various types of uh, inflammatory disorders are there. In those patients, we can suspect innate lymphocytic disorders which needs to be targeted rightly. So these are the various lymphocytic function disorders. Though they are rare, but because of consanguinity and other things, they are little bit common in India as compared to foreign bodies. For them, first and foremost is the diagnostic. Diagnostic innate disorders are usually seen in childhood, acquired in the adulthood. If innate lymphocytic disorder is suspected in a child, how exactly they will present? The lymphocytic function will be abnormal and they will have recurrent infections. If you do the immunoglobulin levels will be low. And in those cases, you have to do the lymphocyte analysis, lymphocyte fraction analysis, where CD4, CD3, various alpha, beta, gamma, delta T cells, all those subtraction analysis will be done. And according to that, we have to diagnose the lymphocytic function disorder. According to that, they have to treat. If it is innate disorder because of some molecular damage, primary treatment remains the bone marrow transplant. Till that time, they have to be on prophylactic medicines for the T lymphocytic or B lymphocytic functional disorder. Acquired, if it is acquired, then primary disease needs to be treated. If it is acquired, then for first and foremost is the multiple myeloma. In multiple myeloma, you have to treat the multiple myeloma properly, and with that, the immunological response goes. Till that time, you can give them immunoglobulins also, because main function of lymphocyte is to produce immunoglobulins. And immunoglobulin levels are low, that leads to the infection again and again. And in those cases, then we have to go for the immunological mechanism. There are various methods to diagnose them, maybe clinical examination and also the lymphocyte analysis and immunoglobulin levels. Nowadays, we have NGS, that is next generation sequencing, which can give us idea about the exact mutation which is happening in the body. That is why the lymphocyte function disorder is happening. So this is all about today's lymphocyte function disorder. So we have discussed about the basic development of the cells. The hematopoietic stem cell develop into the lymphoid series. How the lymphoid cells develop B lymphocyte, T lymphocyte, and the natural killer cell. How the defense work. Lymphocyte response is the secondary response against the highly specific targeted, and B lymphocyte are the cells which produce humoral immunity, producing the antibodies. T lymphocyte produce cytotoxic immunity by killing the cells by the hemophagocytosis or the phagocytosis. And if there is disorder, it can be acquired or the innate immunity. Innate problems are presenting at the birth and needs to be addressed rightly at that time. If it is acquired, it is usually in adulthood because of the various causes like where immunoglobulin levels will be at the point. This is all from me today. Thank you so much. Today it was not possible for me to come up with some what you call PPT presentation. I just quickly went through the guidelines. Next time we'll do it in a better way for sure with good PPT. Thank you so much. This is all for us. Over to you.
Yes, sir. Thank you so much, sir, for
Question
giving
and
your
answer.
valuable. Yeah, definitely, sir. And thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants for joining this session. Sir, I can see, sir, we have received some question from the participants. If you allow, can I take this question?
Yes, Faraj, yes, let's go ahead.
Yeah, the question is, sir, first question is, what are the poor prognostic indicators for chronic lymphocytic leukemia?
So thank you so much, doctor, for asking this question. Today's talk I just specifically restricted for the lymphocytic function disorders, but next time we will cover CLL, chronic lymphocytic leukemia, at stage for sure. To answer this question today, CLL is a disorder of usually old age. It is a common disorder. Many of them don't need even treatment also, but there are some treatment indication for them. And in that also, if some adverse prognostic markers are there, we can think them straight away for the treatment. As we all know that genetic markers nowadays are easily available for us to screen for every patient, like next generation sequencing. And in that, if we get like TP53 mutation, chromosome 1 mutation, if patient has the rapid lymphocyte doubling time, if patient has primary refractory disease, these are the markers which can suggest that there is adverse prognosis. But considering the treatment availability of rituximab, acalabrutinib, ibrutinib, and various other new molecules coming into the picture, doesn't look like CLL remains adverse thing for now. Looks like we have got various treatment options available to the CLL patients. Thank you so much. This is all.
Yeah, thank you so much for answering it really well, sir. I hope that doctor have received his answer. Moving forward, the another question is which patient group are the higher risk of lymphocytic leukemia?
Thank you, doctor, for this interesting question, because all of us think that why this leukemia comes, but particularly for lymphocytic disorder, lymphocytic leukemia, no, there is no any specific group or class where it can come. It is, it has to happen. It will happen to you. CLL per se, acute lymphoblastic leukemia, is a young generation or young population which is affected. In that, yes, it can happen to anyone. But CLL, yes, there is some chance that if family history of CLL is there, chances are that you may get the CLL. So positive family history can be one reason for CLL, but for others we can't say, can't predict who will have the lymphocytic leukemia particularly. Thank you.
Okay, thank you so much for answering, sir. I can see there is couple of questions, sir. We will be taking last question for today's session, last two. And the question is role of imaging in the evolution of lymphocytic function disorder.
Role of
Imaging.
imaging in lymphocytic leukemia. Thank you, doctor. Particularly to look for thymoma is the thing, I think, where we need a good CT scan. SOS for biopsy of that thymoma to prove that it is thymic. So that is one thing. Second thing, whenever there is lymphocytic disorder, if we need to do PET scan, if it is lymphoma or CLL, so extensive of disease, in that case you need imaging. So I think these are two, three roles only the imaging plays when it comes to the lymphocytic disorders. Thank you.
Okay, thank you so much once again, sir. We will be taking last question for today's session related to this topic. And the question is, how is bone marrow aspiration and biopsy used in the evolution of chronic lymphocytic leukemia?
Thank you, doctor, for asking this question. So this CLL, chronic lymphoblastic leukemia, as I already told, next time we'll be discussing extensively on that CLL for sure. So to answer your question, CLL per se, usually if they're asymptomatic, treatment is not indicated initially. It can be diagnosed by flow cytometry on the peripheral blood only. But if at all, whenever treatment is indicated, we intend to do the bone marrow aspect of biopsy to see the extent of involvement, to do the molecular markers on the stem cells, the karyotype on the stem cells, so that we can judge the disease rightly at the start. Sometimes they can present with autoimmune destruction and other things. That can also be sometimes some fibrosis, some other involvement in the bone marrow can also be looked rather than missing on the periphery. Whenever treatment is indicated, we used to go through the bone marrow aspirate and biopsy. If at all treatment is not needed, then there is no role of any bone marrow aspirate biopsy at the frontline diagnosis of CLL. Thank you. Faraj, you are not audible. Faraj, you are mute.
Answering all the questions, sir. It was a really wonderful session from your end, sir. As there is no more question sir, can you hear me now? Uh,
Yes, yes.
sir, can you hear me? Am I audible now? Now,
Yes,
sir.
yes.
Hello, sir. Can you hear me?
Yes, yes,
Hello,
Faraj, no problem.
sir. Can you hear me now? Hello, sir.
Yes,
Can you hear me?
yes,
Sir, am I audible? Am I audible?
yes.
Yes, sir. Thank you so much, sir, for giving. Yeah, thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session
Yes. Thank you. Bye for now. See you next month.
informative. Sir. As there is no more question, with all your permission, shall we close this session? Closing. Hope to see you again with different topic. Hear me now? Hello, sir.